Chair. I believe I saw you in the chat.
Yes, ma'am. Present. Good morning.
Oh, good morning. Thank you. Greg Clauser, I see you on screen. Good morning. All right, Chicky Flowers, are you here with us yet? We may have to wait another moment for Chicky. Andy Fultz, I see you on screen. Good morning. I do not see Kimberly Hendricks on screen. Kimberly, are you with us? Kimberly may not be here yet. Sean Parkman, I see you on screen. Good morning. And Chicky Flowers, I see you on screen. Good morning. All right. And Rose, is Kimberly not able to be with us today?
I didn't hear anything from her, so maybe she's just running a little late.
Okay.
I'm here, you guys. I'm here.
Oh, you are. There
Yes.
you are. I see you. Thank you.
Good morning.
Good morning. All right. And it looks like all of our voting board members are here. Representative Rob Nose, I believe, is not joining us this morning. So he is excused today. And we are expecting a new board member in October, although she still must go through the Senate confirmation process. And I believe she's observing this morning. So that's Emily Wong. I want to welcome her to observing. And soon in the future, she'll be able to participate. Good morning, Emily. Glad you're here.
Good morning.
All right. So we do want to get started with the approval of the August minutes. Do I have anyone who can make a motion on those?
I can make a motion on the minutes as written.
All right, thank you, Greg. Do I have a second on that motion to approve the minutes?
I can second. This is Chicky Flower.
Thank you, Chicky. All right, Dawn, how do you vote on the minutes?
Approve.
Andy, how do you vote on the minutes?
Approve.
Kimberly, how do you vote?
Approve.
Sean, how do you vote?
Approve.
All right, thanks everyone. The minutes have been approved. So first up on the agenda is we want to follow up on an issue from our last board meeting. I believe we have both Umberto Chacon and Julie Marshall here with us from our EAP. So I'll turn it over to the two of you.
All right, thank you. Good morning. You
Hello,
want me to
everyone.
start, Umberto?
Yeah, why don't we just get into the update from the issue that was brought up at the last board meeting, Julie, if you could provide that, that'd be great.
So we appreciate having a few minutes to give you that update from the presentation last month. And, you know, I know we only have 10 minutes, so I'm going to give just a high level overview. And if there's any quick questions people have, we're happy to discuss those. We have involved PEBB staff and been providing them updates and discussing with them, as well as provided information and updates to Sean. So they have had a deeper dive into the situation, but we wanted to give you that overview. So, you know, first upon hearing the information, you know, our first priority was to reach out to the member to make sure they were taken care of. So the day of the meeting, our director of clinical services did reach out, and the member reported that they were satisfied with their provider and the process and didn't want any further assistance at that point. And they were very helpful in providing us information. And because the other piece of that is then investigating, you know, the case and the details of what happened. So our clinical director and his staff did review the case, you know, and overall, the case did follow our standard operating procedures, which I'll talk to you a little bit about. So the first appointment was scheduled within 5 days of the call. And when that provider didn't turn out to be a match, which I will give you more details about because that was part of the concern, when that wasn't a match, we referred the member, according to that member's criteria, to another provider. And what happens is, until that appointment is made, our staff follow and touch that case every day. So they're either talking to the member or talking to the provider. And they were referred to a provider who was unresponsive. That second provider was unresponsive. we were working with the member and the provider on what was going on. When that appeared that was going to cause a delay, we made a third referral. And the member did end up making an appointment and kept that appointment with the provider. But so that last appointment was significantly longer than our 5 to 7 days because the initial referral wasn't a match for the member. So the other concern was around that the member was matched with a Christian counselor when that didn't match the member's belief. And so I think it might help to give you an overview of how we conduct an intake. So when a member calls and wants counseling, our intake counselor takes the member through a series of questions to help match them. Location, clinical specialty, gender, ethnicity, and talk to them about any other criteria that the member might have. Now, I will say it's not an exhaustive list, right? That intake is done by design in terms of trying to design an intake that will get us enough information to make a good match. But it's not exhaustive because that would create a very long intake that also could create a barrier to access. So in this intake, particular intake with the member, it did not come up that the member didn't want a counselor with that Christian affiliation, unfortunately. So the provider, what we referred this member to was Christian, but does work with clients from other faiths and perspectives. So there wasn't any prayer within the session with the member. We don't have counselors on our panel that provide Bible-based counseling. Clinicians approach the clinical topics with neutrality and follow the client's lead on spirituality and religion. So this counselor did meet other criteria that the member requested, but we didn't know, unfortunately, that she had that strong inclination around not wanting someone who had a Christian beliefs as a counselor. So, which is completely understandable. That wasn't a match for that member. So the member was given a fresh set of sessions and re-referred, as I described earlier. So that's kind of the high level overview. I don't know, Umberto, if you have anything to add or if anybody has any additional questions or comments about it.
That's what I was going to ask, if there anyone else with any comments.
I'll just add that I appreciate the thorough follow-up and responsiveness, and I feel convinced, satisfied that the referral delays on the second counselor in particular was kind of isolated. So I feel good about that. I appreciate the response and the thorough investigation. And it's helpful to walk through the process and understand the sorts of questions that are asked in order to get people to a cultural match, and then the questions that are not. So it's just good to know, So I think what I've understood is that there's questions related to gender and ethnicity. And then there's kind of an open question of is there anything else? And that's generally kind of the sorting. And then there's if it doesn't match, then there's a referral. So yeah, that's good. It's clear. Appreciate it. Thank you.
Yeah.
Thank you.
We
Right.
appreciate you bringing it to our attention, and we always, it helps us, identify if there's anything we need to improve. So thank you.
All right. Well, thank you both.
Yeah.
Thanks for coming back.
Of course. All right.
All right.
Have a good
All right.
day,
Take
everyone.
care. All
Yeah,
right,
you
bye-bye.
too.
Thank you.
All right. I believe we are talking about dental plan provider diversity and access today. And Andrew and Tiffany are going to lead on that from Mercer, Andrew Hoffheimer and Tiffany Cleveland. So I'll turn it over to the two of you.
All righty, thank you, Siobhan. I can open it up and I'll hand it off to my colleague here, Trinity, in a minute. But this will be somewhat similar to last month, where Mercer is providing a 30-minute primer on this topic. We're talking about network access standards as well as diversity within dental networks. And then we'll give each of the dental carriers an opportunity to present on those topics as well. And so I have with me today Trinity Cleveland. Trinity is a Mercer dental subject matter expert. She has a really broad range of experience from a clinical setting, working on external quality reviews, and just more generally helping clients develop strategic policies around their dental benefits. And so with that said, I think we can flip it to the next slide, and I will hand it off to Trinity.
Hey, thanks, Andrew. Appreciate it. So hello, everybody. So yeah, as kind of Dan alluded to there, we were going to be talking a little bit about barriers to dental care, Oregon dental providers, and network adequacy considerations, dentist demographics in general, and supporting diversity in the dental workforce, along with building a better dental network. So if we can go and move on to the next slide. So there are, the reason we want a network obviously is to provide access to dental care for our members. But there are other barriers to care that they're primary drivers to better oral health. I'm sorry, I'm stumbling here a little bit this morning. It's only a 1 cup of coffee. So anyways, the dental benefits and coverage, which we won't really talk about today, but that's, one of the first barriers that people run into is, do we have the right benefits at the right cost? Not taking a one size fits all kind of approach. Considerations around full-time, part-time employees, their partners, their dependents, perhaps retirees. They're all going to have different needs when it comes to their oral health. And so making sure the dental benefits and the coverage of services aligns with what those needs are. The second, obviously, is adequate network. And we talk about adequacy, network adequacy, and it can sometimes get lost is, what does that actually mean? One way that I hear commonly defined for network adequacy is a health plan's ability to deliver benefits that are promised by providing reasonable access to enough in-network healthcare services. This is pretty broad, and it really kind of talks to a minimally adequate network. So what is the minimum amount that is needed to service the members and provide the services that are needed? I feel like it goes a bit further than that, though, or should. We're really talking about relationships with providers when we're talking about the network. It's relationships between the plan and the provider and the members and the provider, right? It's not a one-directional street there. Then the third thing is the cultural barriers, and we'll get into this a little bit more later as we're really talking about health equity and provider diversity. It's not just about finding a provider in general, but finding the right provider for you, and someone who looks and thinks like you, has similar beliefs, speaks your language. The network should provide options to all of these variables there. And, we're talking about other barriers are like physical accessibility. Again, we'll get into that on the next slide. So can we just go and move on to slide 4, please? So sometimes we don't consider that there are also hidden barriers to dental care. Phantom networks, for example, is a hidden barrier. This is really when the provider directories are not updated. They may contain incorrect information. Maybe the providers who are listed are not actually accepting new patients. Any kind of misinformation that is put out around the availability of a certain provider to be able to see patients. Non-clinical gatekeepers. This one can be kind of interesting. And as an example here would be, a front office staff not really being very helpful in scheduling appointments. It could be really kind of any non-clinical deterrent. And lack of health literacy, I think, is often forgotten. There's sometimes a question about, whose role is it to really make sure that people are understanding why they should be visiting the dentist? Is it the health plan? Is it the dental plan? Is it the employer? Where are they getting that information? Is it effective information that's being relayed to the members to make sure that they are getting the right care when they need it? We can go to the next slide. So this is kind of a quick look at what dental providers in Oregon and unmet dental needs. This information came from a combination of sources, but primarily KFF, the Kaiser Family Foundation, did a report in this, conjunction with the American Dental Association using some of their 2022 data. By the way, there's links to a couple of these sites that I'll be referencing at the end of the slide, at the end of the deck. So, we do recognize that there is a shortage of healthcare providers in general. Dentistry is not immune to this trend, obviously. We're seeing it all over the place, but for all of the dental workforce, from front office personnel to dentists to specialists to hygienists, assistants, even lab technicians. It is a real problem. So we, want to kind of keep that in mind. But there has been a pretty steady number of dentists in Oregon since about 2010. There's about one dentist per 1,000 Oregon residents. There have been slight increases in pediatric dentists and hygienists, and there's been recently a larger increase in extended practice dental hygienists to help to fill these gaps. One interesting thing that I found actually just a couple of days ago, I came across my LinkedIn, was that ADA, the American Dental Association, has a visual report, like a tableau type of report that is showing the movement of dentists. So moving out of one state into another state, in Oregon is actually showing an increase. So, it kind of, when I look at the numbers that are here, this 31.9% of Oregon population has their needs met for their dental care. That means a lot of people don't have all of their dental needs met. And it kind of makes me wonder, why? What do we do at this? How do we tap into this trend of dentists who are moving to Oregon? How do we make Oregon a more desirable place to increase that number even further? If you can go to the next slide. Thank you. So some things to consider when talking about dental network adequacy is, really understanding what it is that you're measuring, and are we measuring what matters? I think that one thing that really gets overlooked or we lose sight of is the value of a high quality network. And you see here, it says high quality plus low cost equals value. I think most people understand that and would agree with that. But one thing I want to point out here is that the cost to the employee may not be actual financial cost. So we have to look at other issues like time off work to travel for people who are working or living in rural areas. There may not be a dentist that's nearby. They may have to take the day, or a couple of days off to go to visit the next town over, or whatever that might look like. There's also the cost of stress or fear for seeing a new provider, whether they're going to a provider for the first time, or maybe it's been a long time since their last dental visit. Network changes can also create that uncertainty and, really decrease the value of a network if it's, if it's constantly changing. So how do we measure network adequacy? Typically, geo-access reports, things like that are pretty common, measuring time and distance. Can you see a dentist within 30 miles or within 30 minutes? These are just examples, but those are ways that time and distance are considered. Appointment availability is another way that may be considered. So are you able to get the right care when you need it? Are there considerations for preventive services versus routine or urgent or emergent services? Things, ways that people can get in to see their dentist, for something that's come up in an urgent situation or potentially emergency situation instead of going to the ER, for example. That's also one of the reasons why the provider to population ratio comes into play as well. We also want to consider provider types. We're talking about general dentists, specialty practices, pediatrics. Do you have enough orthodontists in the area? Because maybe there's a large population of teenage kids who are needing braces or something like that. Are all of those services available? Another consideration is the cultural consideration here. It's, do they have doctors or providers or minimum staff that can speak the language that the members need and to understand what's going on and what their options are, their choices, to make them feel more comfortable and wanting to go to those providers. Are we considering ethnic or racial competencies and the diversity of the workforce? And then another one that I found was overlooked quite a bit when I was, in the provider space is accessibility. Looking at the physical space, do we have access for people to be able to get into the dental operatory? There are laws around this, but we also know that sometimes dental practices can be small. It could be difficult for people to navigate physically. And what about behavioral considerations? Are the providers trained and experienced in working with people who may have, an autism spectrum diagnoses or something to that, effect? Is everybody prepared to be able to handle these different accessibility issues? And these things also to be considered when we spoke, about phantom networks. Are these labeled or called out specifically in provider directories? So that an individual who's looking for a combination, or any one of these things, or maybe something else, can easily identify providers that will fit their needs the best. Another thing to consider too is, public transportation. So when we look at time and distance, it might be maybe there, is a variety of doctors who are in the area who can see you, or within 30 miles. But if you don't have good transportation, especially maybe from a rural area, maybe you do need assistance, physical assistance to get there. That can be another barrier, another challenge that doesn't need to be. We can go to the next slide, please. This is just a quick look here at demographics, the United States versus Oregon as far as dentists go. You see in the bottom right corner there, about 60.8 per 100,000 is the number of dentists in the US, and 66.1 per 100,000 in Oregon. So Oregon's doing pretty good as far as the number of dentists that we have. But again, looking at other things rather than just that member to provider ratio, or just the time and distance standards, do you have a good mix of female or male providers to meet the needs of the wants of the population, and also looking at race and ethnicity issues as well. We know that people are more likely to see providers regularly if they can relate to them, if they're able to build a relationship with them, if they are able to establish trust with their providers, and they're going to go in and see their providers and accept the recommended services that they need.
Just a quick question on the demographics. So are there also broader demographics on all the hygienists? Because a lot of folks, when they go to the dentist, they see the dentist for a moment, and they spend more time with the hygienist. So I'd be curious to know if those demographics exist and whether they have a better match.
Yeah, that's a really, really great question, and I appreciate you asking that. I don't have the information right now, but I'm sure that it's available. Again, this information actually came from the American Dental Association. And I'm pretty sure the American Dental Hygienists Association has something similar. I can certainly look that up for you and see what it looks like, if that would be helpful.
So we could just have it available for board members in the future. Thanks.
Absolutely. If you go to the next slide, please. So, we talk about this need for diversity and in the dental workforce. Again, it's a huge struggle everywhere, even just to maintain the current workforce that we have. So looking at ways to really support diversity, considering it as an investment in health equity. Again, people want to see providers who are like them and who they can relate to. So this is important. So a few areas that can be touched on, just highlights here. And of course, there are many others and probably things that these are probably already things that are being done, but just kind of as a reminder. Partnering with colleges and universities to expand dental programs is one that I think is very important. There is actually, I would even add not only dental programs, but dental therapy programs in Oregon. I know that dental therapy is a new and upcoming field there. And I know that there is a desire to start to really look at how they can integrate a dental therapy programs into their dental schools or something similar. Helping to fund scholarship opportunities, and also just keeping in mind the entire dental workforce. And we're thinking about diversity, right? The dentist and very important, obviously, they tend to be the leads of the practice. But as you mentioned too, right, dental hygienists tend to spend a lot more time with their patients more frequently anyways, with more frequent visits and so forth. There's an easier opportunity to build relationships with them and with the front office staff, any administrative personnel as well who can help, again, in translating or just building that initial rapport with a patient for that, first phone call. All of it is important. So keep the entire dental workforce in consideration. Not to mention, you bring in somebody as a dental assistant and they have the opportunity to really learn. And this kind of goes into the next one about offer coaching and mentoring opportunities and partnering with local clinics to provide training for entry-level positions. So entry-level could even be dental assisting, again, administrative front office staff. It's a real great gateway to other provider type positions. I myself started off as a dental assistant and fell in love with the world of dentistry and furthered my education from there. And so it's a good opportunity to be able to really bring people in who, maybe aren't ready just right out of high school to go jump into, 6 years, 8 years to be a dentist. Also really thinking more about the future. We want to encourage younger students to engage in STEM learning, and there are ways to do that by just participating in career day events or, sponsoring a STEM related activity at a school. When I say younger, I think we tend to focus on students in the high school age range. That historically has been the thing. But really looking younger than that, junior high, grade school, get them interested in learning in the sciences early and kind of put that little seed in their minds about dentistry as a possible career choice. Now we can go to the next slide. Thank you. This one's kind of busy. See if I can work through this a little bit better for you. So again, building a better dental network. Typically we have dental practices that are like, private practice settings or becoming more and more popular, group practice or DSO type of arrangements, DSO being dental support organization. And this is where dentists and hygienists and everybody kind of, does their thing and services are provided there. But we are starting to see a lot more use, especially because of COVID, a lot more use of teledentistry, even just for screening of emergency services or providing, some whatever kind of guidance. Obviously, you can't clean somebody's teeth through teledentistry, but you can use that, for instance, for mobile dental services or at other locations that are away from, your typical brick and mortar private or group practice setting. So, where you can have a dental hygienist or a dental therapist who's providing their preventive services and, using teledentistry to share patient information around, their x-rays that they're taking that day, what their findings are, what the recommendations are, getting a diagnosis from the dentist. I feel like this is a really good opportunity, again, for people who are in those rural areas, but may take quite a bit of time to get to their closest provider. If you are seeing your hygienist through a mobile or a remote service location, maybe utilizing integrated care models to help to support that, using co-locating a hygienist or a dental therapist into a medical facility, for instance, or they can use teledentistry to connect with their contracted dentist and, do the preventive stuff, get the diagnoses needed so that when they do make the drive to see the dentist for restorative care, they're not having to go back and forth, drive up one day, get your diagnosis, make an appointment for another week, drive back again to get the services done. It takes a lot of time, and this could be a way to help to bridge that. Also looking at, we talked a little bit about alternative provider types, being dental therapy, is one of them. But also using, maybe they are not dental provider types, but more like traditional providers, non-health or non-clinical providers to help to coordinate the care, across the services to help to make sure that these integrated care models, for instance, are working in the best interest and they are efficient and effective for the members. Also want to consider different strategic initiatives that can support the growth of the dental workforce in general, or to expand opportunities for care, expanding scope of practice for dental hygienists, dental therapists, even dental assistants, opening up some of those avenues for them. There's currently, for instance, a dentist and hygienist licensure compact, and I'm butchering the name of it right now, but there's a compact that is being sent around that I think Washington has enacted in legislation recently. So what this does is basically allows for portability of licensure between state lines for the states that accept this into their Practice Act or wherever it belongs. And so, supporting things like that may also help to bring in additional providers to help to fill the network. And I am going to pause there, see if there are any questions about any of these things that we've talked about, or specifically to this slide.
I don't have any questions, just a comment that I know we're going to hear from our carriers next, and it feels like there are barriers in place that there needs to be a lot more communication maybe with folks to get them over some of the barriers. And I'm just thinking, I know that a few years ago, we talked about, having different ways for folks when they show up at the dentist to get their anxiety treated, or, there's just a lot of things that come into play for folks to get through the door to get their preventative care. And, what are the ways that our carriers are thinking about breaking down those barriers? So we can hear from them soon, but I just wanted to make that comment.
Thank you. Questions from anybody else, or can... Okay. Well, if there's nothing else, then I thank you for your time. Andrew, I'm sorry, did you have something to add? I saw you came off mute.
No, I suppose I can make one comment on one of the barriers that you referenced at the beginning around health literacy, which is a challenging barrier really across all benefits. When staff and Mercer and CARES collaborate on member-facing communications, we target a 6th to 8th grade reading level, which can be difficult to achieve, with certain benefits concepts. But that is our goal, to try to make these concepts as accessible as possible. In addition to some other efforts that we do around translating communications and offering folks phone numbers for if they speak a language that we don't translate our materials into, there's phone numbers they can call to speak with someone. So those translation services also are an effort to try to take the edge off some of those barriers that we're dealing with. Yes, Dawn, I see you have your hand up.
Thank you. Thank you for this work and this presentation. Dawn Mautner, Medicaid Medical Director, she, her, and Aya are my pronouns. The question I have might be more of a comment, but there are two very dynamic things happening right now from my angle. One is certainly our evolution to center equity and the acknowledgement that some populations, some groups within our communities are more highly impacted by different ones of these barriers than others. That's part of what is in the underpinning of your observations. There are things like systemic racism, but also sort of ableism and the ability of people to access different kinds of environments and the acceptability of different kinds of treatments and opportunities to get care. And the second observation I want to make about that in thinking about centering equity is the really remarkable moment that we are in the wake of the pandemic, to consider telehealth services and all the ways that it can impact health outcomes and costs, as well as, again, equity. We discovered in the medical delivery of telehealth services, during COVID, that some of us had a bit of a Pollyanna idea that it would help to eliminate health inequities. And while there were some inequities that were improved by access to telehealth services, it also turns out that there were some equity issues that were exacerbated, worsened, and that providers at time would push the telehealth delivery opportunity to a place where it wasn't as much centered on what the clients needed as it was on the fact that it's cheaper to deliver telehealth services than in-person services. And so they would, for example, require a telehealth visit before they would let somebody come into the office for a specialty visit. And so as we think about expanding our dental network and doing a better job of delivering the services that people need in the way and the place and the time that they need it, I appreciate the continued sort of focusing creativity around ensuring that teledentistry is implemented in a way that improves inequities rather than exacerbating them, and the creativity of all the members of the systems in leveraging that sort of new territory in the service of their own agendas is something to tune into as our evaluation of adequacy of network and access gets more refined and sophisticated to take that into account. It's new territory, and in medical as well as dental. So thank you. Sorry, that was a long spiel.
Thank you for your comments. I appreciate that. Very helpful. Okay, if nothing else, then I will give it back.
All right, so I believe we have Moda presenting first. And we have Terry Baricello. And is anyone joining Terry? I think it's just Terry.
It's just me today, but I
Great.
would invite my team to help me out if they would like to join at any time. So good morning, everybody. I'm Terry Barrichello. I'm the Vice President and Chief Dental Officer for Delta Dental of Oregon and Alaska, and MODA, for anybody who I have not had a chance to meet before. And I apologize. I'm at a National Association of Dental Plans conference right now, so I have a hotel room back room today, and hopefully the fan is not too loud and disruptive. And today, Mercer has asked the dental plans to present on provider diversity and member access. So has set forth a number of questions. And as I go through my slides, please feel free to interrupt at any time and ask questions along the way. So let's go ahead and get started. Rose, if you don't mind to go ahead and advance. So the objectives here just basically is an overview of the questions that Mercer set forth. So go ahead and go to the next slide, and we're going to jump into our network and really looking at access. So what you see before you is a geo access overview. And for Delta Dental, we're really proud of our network access. Delta Dental of Oregon has the largest dental network in the state of any of the national carriers. We track and monitor access in a couple of different ways. And the first, which you see before you, is the geo access reporting. And this process maps where employees or members reside in relationship to where we have contracted dental providers. This report was run on September 6th, and the map shows where PEBB employees with access as green dots and employees without access as red dots. And we use CMS requirements for ACA plans for what meets access. And those definitions are listed right below the map. So for example, in the large metro and metro areas, access means there are at least 5 providers within, I got to move things around here, within 30 miles of the member. The results of this mapping demonstrate robust access for dental providers for PEBB members. PEBB's on an active PPO plan design, which means members get the best discounts for, and their benefits go further when they see a PPO provider. So out of just over 36,000 employees, only 41 don't meet the CMS standard for access to a PPO dentist. So put another way, 99.9% have access to a dentist. Our plan design uses our Premier network as a wraparound. And since Premier providers are participating or in network and are held to their negotiated fees and are prohibited from balance billing, when a Premier network is also factored in, only 34 or 0.09% members don't meet the access standard. The geo access exercise also provides us the average distance to the first, second, and third closest providers. And that table is on the bottom left. The average distance to the third closest provider is only 2.6 miles. So any questions on that one? So we can go ahead and go to the next slide. So the second way we monitor access is by looking at claims utilization, which tells us where members are choosing to actually receive their care. So based on claims from July of last year through June of this year, 98% of PEBB members' claims came from in-network providers, which is outstanding. So to put that in perspective, according to Fluent, which is a dental analytics company, they manage a multi-payer database with claims from over 70 regional and national dental payers. In 2021, and as of August of last year, the average percentage of claims that processes in-network nationally is 79%. So the PEBB performance is far exceeding that. You can go ahead and go on to the next slide. So while we're obviously really proud of our network strength, the job is never done because network churn is always a priority for us. We take really great care in maintaining the relationships we have with our contracted providers and work hard to recruit those who are not yet contracted. In fact, no other carrier really takes the care that we do in going into provider offices to make sure that to maintain the relationships, to problem solve, and to partner with them. So some of the ongoing activities that we do, from the member side, if there is a provider that is not in network, we take provider nominations. They can actually let us know that their provider is not yet in network, and we will do specific outreach to them. We'll do in-person visits. We do provider workshops and trainings for them virtually and in person. And we also are present at all of their component dental society meetings. No other carrier puts themselves out in the field like that to really partner with providers. And in fact, our network strength is for the available or achievable market share. We contract with over 92% of the dentists in Oregon. Go ahead and go to the next slide. And I believe those strategies are working because this slide demonstrates that. Across the bottom x-axis is time. And these are end of year results with obviously the exception of 2023. And the y-axis is the base starts at 94%. So the gray block indicates the percent of our network retained. And at our lowest point during the pandemic, our retention rate was still 96%. The green color above represents retirements, which you see account for a significant amount of our turnover, especially in 2020. We saw both in Oregon and Alaska, and actually across the Delta system, there was a really significant increase in the amount of dentists retiring during the 2020-2021 period of time. And in fact, if you add up all the terminations from 2019 to date in 2023, 60% of provider terms have been for retirement reasons. And then finally at the top in blue, that's the area that you would want to pay attention to in terms of what we call voluntary terms. And that has run at 1%. And these would be providers who are terming because they disagree with something they don't, whether it's processing policies or fees, or what we're seeing occasionally is they're terming all third-party contracts. And we actually see very, very little of that. And I'll pause and see if there's any questions. Okay, go ahead and move on. And then addressing teledentistry, which is timely given the conversation we just had. So in 2019, we piloted a teledentistry portal on our member dashboard, which was really fortuitous given that, as we all know, that preceded March 2020 when dental offices were all closed due to the pandemic. But surprisingly, we didn't really see a lot of activity through that. So later in 2021, we made some changes to the functionality on the member dashboard and tried to make the member experience more streamlined, and really did a deep dive in reviewing the utilization and member engagement. And it actually made sense at that time for us to remove the teledentistry portal feature from the member side, because from just similar to the medical space, from the privately contracted or individually contracted network side of things, most dental offices were offering teledentistry services directly to their patients within their practice, and they were not needing to utilize our particular portal. So for now, it appears that that modality is more successful at the practice level. For that part of teledentistry, there's a lot, that term I think is kind of an umbrella term for a lot of different models, as was referenced in the prior presentation. And our Delta dental peers across the system, they seem to be coming to the same conclusion. Some other Delta member companies have worked with teledentistry vendors and different platforms over the last few years, and nothing really seems to have gotten traction from the payer side. One company actually engaged with 2 different vendors, and over the course of a couple of years actually had 14 member interactions between the 2 platforms. So it really does seem that it's really at a practice level seems to be more successful. And I'm going to guess or bet that when you hear from Kaiser or Willamette, which is more that practice level, that they're going to have a lot more success in that teledentistry in engagement, more triage level. I will say on a different version of teledentistry where we are having we're getting our legs underneath us. We're running a pilot project with OHSU in the Medicaid space, in co-locating a hygienist in one of their primary pediatric clinics and doing screenings and preventive services in that children's clinic as it's connected to one of our Medicaid clinics under our umbrella and in a hub and spoke kind of environment. And we're having good success there and hoping that we can expand that out. So more to come and more to learn under that side of teledentistry. So I think there's definitely application there in the future. Go ahead and move on to the next slide. So moving into the diversity side of the presentation, a few years ago, we enhanced the functionality of our provider search tool by expanding the searchable demographic attributes, which you can kind of see before you for members to search by. Since that time, our professional relations team has made considerable efforts to collect that information. And this is the team that directly reports to me, because so I can attest to how incredibly hard they have been trying to collect this information. And we do so at both the provider and the clinic level. So trying to understand holistically these attributes for our members to be able to search by. I'm sorry to say that we have made really slow progress. Providers, dentists, and clinics have so far been really hesitant to share this level of detail with us. We have even offered incentives, we've offered prizes, we've offered lunches for submitting the information. But even with those carrots, we've only collected data on 5% of our network. We continue to prioritize outreach specifically to dentists that are most utilized by OEB and PEBB members, but we're just inching along. And I think it's going to be an arc. I think there's some questions in their minds as to why we're wanting to collect this information and how it's going to be used. So I think it's going to just take time for them to understand and to build trust to see and prove how it's going to be used in a safe manner, and that it's actually going to enhance their presence online and searchability. But I know this is important to members and transparency and being able to choose a provider that is the best fit for a member. So it's something that we'll continue to prioritize.
I just have a question with this list. Are there some things that dentists are providing information on and other things are not? For example, not on identity, but they are on ADA accessibility or materials available in other formats? I mean, or is it just across the board?
That's a good question. 5%. That's a really good question. I haven't heard that when we get a survey that they're only doing some and not others. So I'll take that back and ask. Yeah, I don't know the answer to that.
Oh, so it's only through, I mean, I guess I would wonder if some of these things would just come up as part of the contracting too.
Well, some of it does. I mean, obviously we do get some on contracting and through the credentialing cycle, but on the survey that we're doing, I don't know if they are. I would want to ask my PR team if just in their conversations with offices, what kind of feedback they're getting in relation to that question. So I think they would get a little more nuanced answer there.
Okay, thanks.
Okay, go ahead and go on to the next slide. So I don't know that I need to go through this because I think it was covered in the prior presentation, but really I just wanted to, as we talk about, one of the questions was increasing the diversity of our network. And as I thought about that, it's tough because as I talked about before, we already contract with, over 92% of the dentists in Oregon. And then thinking about, well, part of the problem is the workforce in Oregon is not, or the dentist piece of the workforce in Oregon is just not that diverse. So I wanted to try to demonstrate that, but I think the prior presenter did a really nice job of doing that. So I don't know that we need to spend any more time going over this. So I think we can go ahead and go to the next slide. So what I will do is talk about what we're doing in the Delta system, which is there's some really cool things happening here. So last year through our Delta Dental Institute, the Drive Greater Diversity in the Oral Health Workforce campaign was launched. launched, and there are 4 pillars that make up this campaign. The first is establishing the Oral Health Diversity Fund, and I'm going to hold off describing this because I have a slide dedicated to it in a moment. The second is to make dental education more accessible by offering the diversity dental student scholarships. And these are given annually, and it's a scholarship awarded to students from systemically disadvantaged racial and ethnic backgrounds entering dental schools. And they're $25,000 scholarships. And then under the pillar of propelling new research, the Institute has sponsored the Harvard School of Dental Medicine's new research on oral health workforce. And they actually just recently published results in the Journal of the Medical Association, in the Health Forum, and found that by expanding the dental workforce in oral health professional shortage areas through the National Health Service Corps, the burden of dental caries or cavities among children is reduced in underserved areas and is cost effective. That's just one piece. And those research projects will continue with different areas of focus. And then the final pillar is to engage with our communities, which has always been a focus under the Delta Dental Plans Association. It's just really ensuring that part of that focus continues to be on oral health education and workforce development. So nearly a quarter of the Delta Dental community investments in 2022 were dedicated to oral health education and workforce development. Go ahead and go to the next slide. And this actually, you can go ahead and skip this one as well. It's repetitive. And this is the Oral Health Diversity Fund. And this is something that we're all in the Delta system really proud of. It is a first of its kind, an industry leading fund, which will invest in upstream solutions. So we know that we need workforce solutions now. It's a significant like I feel it in my own clinics, near crisis situation in terms of a shortage of hygienists and assistants, and even dentists and of any like in all positions, it's hard to find candidates, but we also know we need a workforce that mirrors the population that we serve. So we need these solutions now, and we're working on strategies, obviously, to remedy that. But we also have to think about tomorrow, and we have to think about 20 years from now. So this fund is meant to help build a diverse pipeline of dentists, of hygienists and assistants by starting with the very young. And I know that I pulled this from a different slide deck. So I know it says the application, there's a link to the application site. The deadline actually for this year has already passed, but it is an annual, this is an annual thing. These get awarded at, there's a national conference for dental and craniofacial research in the spring. So these get awarded at that annual conference there. And it's something that obviously will take a long time to play out, but the workforce issue and the diversity in workforce issue will take a long time to turn around. But if we start now and think down the road, I think we will build a really robust foundation that will hopefully be a solid solution. So that concludes my presentation. I'm happy to take any questions from the group.
All right, I'm not seeing any questions. Appreciate all of this information. Thank you so much. All right, I believe we're going to move to our next presentation. We have Kaiser with us. We have Daniel Filstrom and Santo Graciano.
Hi, good morning. Can you hear me?
I can. Good morning. Go ahead.
Hi, I'm Dan Pilstrom. I'm Chief Dental Officer with Permanente Dental Associates. And Santo, do you want to introduce yourself?
Yeah, I'm Santo Graziano, Director of Operations with KP Dental.
So we're going to tag team the presentation, and please just interrupt if you have questions as we go along. Santo, do you want to kick us off?
Thanks, Dan. So yeah, we'll go over our network adequacy, getting in some details about where we are geographically, access to services, current and historical performance, and then our efforts that we have in play right now to improve upon those goals. And then Dan will talk about our health equity initiative, strategy, and meeting our members' diverse needs. So just to kind of go over a quick refresh, we've got our 21 offices with roughly 160 dentists and 191 hygienists. We've been serving this market since 1974 with our integrated model. So coming up on 50 years. So nearly half of our facilities are co-located with a medical office, which really gives us an advantage for that integration. And 4 of those offices listed there, we have an LPN embedded in the office to close some of those medical care gaps while you're visiting the dentist. And then, another aspect of this for convenience of care is that at least one office per geographic area that we have is open on a Saturday. And we rotate within those areas to make sure that, if it's far out east or closer in, that we're providing access to patients at a convenient time on a Saturday. So on the next slide there, we can go into, so far this year, we've added 13,000 dental appointments to the program compared to last year. We've hired 49 assistants and hygienists so far this year as well, and we'll continue our recruiting efforts. One of those recruitment efforts that we're really proud of is partnering with Portland Community College. We actually do a community outreach to find students that otherwise wouldn't be entering into a college program to become dental assistants. Many of these come from families that have never gone to college or taken any college coursework, or first generation migrants. And so it's been a great partnership and great to really see us help develop a diverse workforce. And then how we get into some of our network adequacy is making sure that 90% of those members fall within 30 miles of the area we live. And I think, that's not a challenge that we have specifically like in Clark and Cowlitz counties. That time distance, 98% are being served within that. Our access standards, we measure our emergents and urgents to make sure that they're being seen in a timely fashion. And currently 98% of the emergent and urgents or over are being seen within 2 days. So that including the urgent group in that. And then we continue to benchmark off of our goal for this year is that 55% of our members are appointed within 2 weeks of either requesting the appointment or within a 2-week time frame of when they're actually due for care by treatment plan. So on the next slide, I'll show you a little bit about some of our focus area on filling the appointments and whether they're used. We talked about we've added a lot of access this year, but the utilization of that overall is pretty solid. So for our hygienist, roughly 4% cancel, 4% don't show up, but only 1% or less is actually going unfilled of what we build. And this is a big historical view back to 2021 January in comparison. So sorry, it might be a little small for looking at. The other takeaway there is that our dentist, a little bit different, slightly less, 3% cancel, 3% no show, but we had 7% showing as not scheduled. Part of that is some adjustments in the template, so to speak, and realistically, how fill can that be? So we have some adjustments to hopefully enhance the fill rate in that category. The ways that we go about doing that is that automated reminder calls. In addition to kp.org, if they're signed up on that, you get that push notification or email, however you've selected that to come to you, giving you the opportunity to confirm and do early check-in, which significantly increases the likelihood of that patient arriving to their appointment. Besides that, we're still doing live confirmation calls for most patients. So a live body in addition to those automated ways of trying to do it. and working our short notice cancellations with outreach to patients that we know are ready to be seen. On our next slide there, we talked a little bit about the additional hygiene appointments, 14,000 for them, 3,000 for general dentistry, and our goal of reaching that 55%. And we can pull this by each of the subspecialties, pediatrics, orthodontia, and see how each of those categories is doing as well. So we're making great efforts and definitely plan to hit that. We have some tactics that we're working through to make sure that we can reach our goal of 75% of those patients being appointed within the 2-week window by 2025. Next, I'll talk a little bit about our other ways we're going about those goals. So our continued recruiting, our dental assistant program. We've talked a little bit about the text, email reminders when you're due for an appointment, that you also can get pushed a scheduling ticket allowing you to appoint online as well. So we have a lot of different pieces in play there, and our virtual dentistry. Member outreach specific. So we currently are doing some outreach, and then PEBB is going to be in Q4. So we'll do that for different groups that we're trying to say, hey, you're overdue, and we want to get you in and be seen. Next slide, I'll go a little bit more into virtual dentistry, and I think we've got an awesome platform for it. So we have 24/7 advice available. Email through kp.org is always an available option as well. And then our telephone and video visits. So 20% of our teledentistry visits are resolved without the patient having to come in face to face. And again, as somebody mentioned before, dentistry, sometimes you just have to get in the mouth to resolve. So 20% is looking pretty good. And we have almost 11,000 virtual visits completed so far this year. And for email, we're almost at 1,400. That number grows daily of patients that are connected, and our resolution is 90% of those within 24 hours about it. So we do have more work happening with our video visits, expanding what visit types that we would be able to do, and what specialist consultations that there might be, as well as asynchronous hygiene exams. So a lot of fun things that we're looking into to expand what our virtual platform is to make accessing care easier for everyone. All right. And I think Dan will talk a little bit about our
I think
philosophy.
I'm up next.
Yeah.
You want to change the slide? So at Kaiser Permanente, we have a rich history of serving diverse populations, and we really tried to weave equity and diversity into the entire organization through the workplace by attracting and retaining diverse providers and assistants and hygienists and front desk staff, by creating an environment for patients on the care delivery side where they see providers and staff that look like them, that know their languages, and if we don't know their language, we can get them an interpreter in the moment, which really helps break down barriers for communication. And then looking at serving our communities that we serve, and this is just part of our DNA as a not-for-profit. I know this year, and a new initiative is working with Northwest medical teams to provide free care in the community, and I think we've done about 50 of those clinics since we started last year. So we really take a holistic approach to care delivery. If we're going to be successful at welcoming a diverse population of patients into our office and be successful at caring for them, we've got to have this kind of wraparound service and look at it holistically. If you want to go to the next slide, I'll get into some of the details. So one of the things I'm really proud of and I think it's underappreciated, is when you can't communicate with a patient because you don't know their language, it creates a huge barrier to connecting with the patient, not only from a just educational standpoint, but understanding the disease level and the course of treatment. One of the things that we have, which I'm really proud of, and as a provider who works in the office, it's just an amazing tool, is either in person or live video with an interpreter at all of our offices. In fact, there were 342 PEBB visits within 2023 where we utilized a service like this. We also have in-person interpreters that come into the office as well. So it's an amazing resource to have, and I feel really lucky to be able to provide that to our members. A really important part of understanding what barriers patients face is understanding what social drivers of health. So these social determinants of health, things like transportation, food insecurity, housing insecurity. There's a whole bunch of things that are going on in our patients' lives that affect their ability to get care. And if we don't have an understanding of those, we're not going to be successful getting them that care. So Kaiser Permanente does surveys and connects members with resources to help address some of those social determinants of health. And the dental program is part of that sort of infrastructure. And then we do also financial assistance. So up to $2,000 per year is offered to dental members whose annual gross household income is no greater than 300% of the federal poverty guideline. And in 2023, 30 PEBB members qualified for that, and we provided over $14,000 for dental services to those PEBB members. On the lower right, you can see kind of everything we've been talking about, starting from what Trinity talked about, which is just that populations have different. We know that our populations don't get care at the same levels, and this is something that all of the health systems are trying to work through, is understanding why do Hispanics versus Latinos versus white have different levels where they access care. So that's just such a key thing of understanding how to be successful with managing and treating patients. And so these are some of the tools that you're getting at. One of the future initiatives that Kaiser's working on is the Black Center for Health and Wellness, and it's going to be an office in North Interstate campus that specifically tailors to African American patients to try to provide wraparound services around medical and dental. So that's in development. Want to go to the next slide? One of the things that you talked at I think Trinity talked at the beginning of the session here about transportation and just getting to all the appointments that you need for your healthcare. And we feel that medical dental integration is one of the ways that we provide that access to care and break down some of those barriers to care. This is some of the statistics from 2022 on the number of medical care gaps closed in the dental office. And we have specific data on PEBB members as well. We do a lot of work around trying to integrate care so that when patients come to the dental office, if they have diabetes and they need a blood draw, we can get that service for them. Or we can remind them to get it and stop at the nurse station to get that. Many of our offices have licensed practical nurses that are providing that care in the dental setting. I just had a patient yesterday who got her flu shot after our dental visit because it's flu shot season. So it's such a great way of trying to break down some of those barriers so they don't have to yet make another trip to another doctor office or to get that kind of care. So we really feel like it's an important part of the total feature of our health system. Some of the top 5 care gaps that were closed for PEBB members included immunizations. I think there was over 1,000 immunizations given to PEBB members at a dental visit, 150 lab tests, 217 cancer screenings. And then we also schedule things like well child visits and follow-up medical appointments for those patients that are due. I think there's a hand up.
Hi, thanks. Just have a question on the co-located facilities. Does Kaiser do any steerage to those facilities? So if a member is identified as having sort of complex needs, perhaps for both dental and medical, are they steered to those co-located facilities, or is it more a matter of, members will go, since Kaiser has distinct service areas, members will just go to whatever facility is sort of closest to them?
Generally, they go to facility that's closest to them. That's a really interesting idea. I've never thought about that, about steering patients to specific facilities for that reason. We find that members tend to just go to the clinics that are closest to them. And all of our offices do offer, at least at a minimum, they advise patients on what the care gaps they're due for and can advise them on how to get them closed. So because we don't have nurses at all of our offices. And I think that was our last slide.
We do have another question from Chicky. Go ahead.
Sure.
Good morning, Chicky Flowers. This is purely out of curiosity. Have you all ever considered mobile dental clinics so that you can go to the patients versus the patients coming to you?
Yeah, we have. And we've done it through the Medical Teams International because they have a great system of mobile clinics. And we have dentists and hygienists and assistants that serve on those vans. They don't specifically, see Kaiser members, of course. It's a lot of logistics to keep those trucks going, and so we haven't pursued that as a strategy to say, go to a school and try to see our members at their place of work or school or something. But I know it's a model out there that talk about breaking down barriers. That's a great way of doing that.
Thank you. That was it. I was just very, very curious. Thank you, Phil.
Mm-hmm.
Any other questions? All right. Well, thank you so much, both of you. So what's next on the agenda is a break. We are going to take a 10-minute break. So if folks can plan to get back at 11:01, I'll put it in the chat. Thanks, everyone. See you soon.
Oh. Darling wife, are you home? What's your thoughts?
All right, well, welcome back from break, everyone. We have folks here from Willamette Dental. We have Mark Chambers, Tiffany Nicholson, and Ryan Kamasato. Are folks all here and ready to present?
We are.
Okay, great. I'll turn it over to you.
Thank you. Hey, we're glad to be here with you today, and it's been great hearing the other two presentations from the other providers, and to be able to tell you, what we're doing to help with network adequacy, and also making sure that we have a diverse workforce at Willamette that can meet the needs of our patients. On my next slide, first want to share with you kind of what our network looks like. We are currently in 3 states, the state of Washington, Oregon, and Idaho. We have just shy of 50 offices. And as you can see from the heat map here, the light green are those patients that would fall within a 60-mile radius of an office. The darker blue, 90 miles, and 130 miles is the light blue. As you can see, that I-5 corridor, as you head down through Portland, Eugene, and down south, really is pretty heavily covered by offices where patients are within that 60-mile radius. When we start to get into Eastern Washington and more rural areas, the access to care is a little less in those areas. But they do have access to other states. A lot of our Eastern Oregon patients will go to our Richland office, or will head over into the Treasure Valley. We actually just recently, about 3 months ago, opened up an office in Nampa, Idaho, which is about a 30-minute drive from the Oregon border. And we've seen a large influx of patients, a lot of whom have employees coming over from the state of Oregon to utilize that closer office. But currently, we see about 10.5% of our patients through PEBB that are actually attending offices outside of the state of Oregon and utilizing that opportunity. On my next slide, I want to share a little bit about teledentistry and what we have been doing. During COVID, we had dedicated providers that were only doing teledentistry. And we learned a lot from that pilot. There were some really positive things that we got from that. We were able to deliver or help people with their care at a time where they didn't feel comfortable coming into the offices. And we're also able to help those patients that were maybe quarantined or were not healthy enough to come into an office. But we did find that there were limitations that sometimes we need an X-ray to be able to provide a definitive diagnosis. Sometimes we need to look in the mouth and see what the oral condition consists of. We also found that patients really wanted to see their provider with whom they had a relationship. If they had been seeing, Dr. Armstrong for the last 8 years, they wanted to go see Dr. Armstrong, or they wanted to talk to Dr. Armstrong. And so we've made a few kind of modifications of our teledentistry program, and we've tried to focus it more on the local office level. And we do that in a couple ways. Every day, right before I wrap up my morning, I have a list of patients that have called in that, had questions or, just wanted to speak with me. And I reach out to them right before lunch, and I reach out to them at the end of the day. And similar to how Kaiser reported, there are a lot of times that we can answer questions that save the patient time of being able to come into the office. It saves money and the cost of having a patient come in and receive dental treatment at the office. Where we've also found it very beneficial is that at each office we have care advocates. Care advocates, their job is to be an advocate for each of our patients, to reach out, to encourage preventative care, to make sure that they're following through with recalls and the preventative instructions that we had given them. The care advocates are also a resource for patients to call in and to have kind of the simple, straightforward questions answered. without having to come in for a dental visit. But for the more complicated questions, those are the ones that get diverted to the doctors and end up on the doctor's desk to call the patient back. And we found that this outreach to patients has been really quite successful. And as you know, we all live such busy lives. And I know for me personally, to get away from work, to go to a doctor visit or go to for a dental visit, it's easy because I'm there every day, right? But for medical visits, it's hard to get away from work to go to medical and dental visits. And this is another opportunity where we can do to help our patients. On my next slide, I just want to touch on our current average access times. We look at average access times as just kind of a guide to see how we're doing in terms of how long does it take patients to get in for an appointment. And our goal is that every patient is given the opportunity to schedule a hygiene appointment within 3 weeks and or an operative, so like a filling, root canal, non-emergent restorative treatment within 4 weeks or 28 days. For emergency patients, if we have a patient call in, we want to get them in within 24 to 48 hours. I'll give you an example. Yesterday morning, I woke up and I got a text message from one of my neighbors who is not one of my patients. I had not seen him before in the past, and he just said, hey, I reached out to my private practice doctor in town and I have a terrible toothache, and he said he couldn't get me in until the end of the week. And I can tell you, and I imagine the other dentists would agree that are on the call today, that, you know, having somebody wait a week with a toothache is not acceptable. We need to get patients in, and so we have time blocked out on each provider schedule to get them in within that 24 to 48 hour window. One other thing I'd draw attention to is that we have some work to do still in Oregon, and Ryan here in a little bit will talk about efforts that we're doing to recruit more providers. Some of the other groups that talked about, it's a tight labor market out there, and the things we're doing to better recruit. But you can see with Oregon, we are at 24 days, state of Washington 20, and Idaho 15. We're working to get that down. I see someone has a question.
Well, thank you very much. I see the average for Oregon's 24 days. I was just wondering, is there a big difference between the area of Oregon as far as, you know, are some below 10, are some above 30? And maybe if you could address the ones that would be significantly longer than 24 days, that would be great. Thank you.
Yeah, and there are geographical differences. In fact, that is the perfect question to segue into Tiffany's next slide. So maybe she can answer that.
Yeah, so Ollie, that is an average. So we do have certain areas like our Portland metro, which are seeing a lot sooner than that average of 24 days. And then we have geographical areas that are not at goal at all. So if we could go to the next slide, Rose. So these are the ones that we are kind of hearing some member frustrations about. So we did want to highlight what's happening in these specific areas. So Lane County, this includes both our Eugene and our Springfield locations. So just a few months back, we had multiple providers that left those offices, kind of just an unfortunate series of events. Multiple providers left at once due to retirement, moving out of the area, and then another provider not returning from medical leave. So right now in Eugene and Springfield, we do currently have a callback list for patients. So if there are not any appointments available within 12 weeks, then those patients are being placed on a callback list, and that list is being worked daily as soon as appointments become available. We do, as Dr. Chambers mentioned, we do have emergency appointments available. That time is blocked for each day, so members are still being seen for dental emergencies within that 24 to 48 hours. Moving to Lynn County, so this is our Albany office. We also have ongoing recruiting efforts for 2 dentists in our Albany office. Currently a callback list again for patients that can't be accommodated within 12 weeks. That 12 weeks is the farthest that we book out. Currently, that's what our provider schedules are opened out to. So that's why that 12-week thing that you're seeing is kind of a common theme. Again, though, for our Albany office, we do have daily emergency appointments available, and patients are being seen within that 24 to 48 hour guidelines. Lastly, Deschutes County. So this is specific to our Bend office. We still have ongoing recruiting efforts for a second provider for that office. As there's no neighboring clinic to that Bend office within a reasonable distance, we do have a participating provider that will assist with emergency appointments when that Bend provider is not available, just to ensure that that emergency access is still available. And right now in Bend, those appointments are currently being scheduled within 9 to 10 weeks. As we go to the next slide, we're going to discuss kind of some staffing solutions. This slide is...
Before going to the next slide, I just wanted to point out, we have also been hearing from quite a few folks from Douglas, where you closed a clinic, and as well as Coos and Curry counties. So I know they're not called out here. I've been hearing from folks in those areas even as recently as the last month. So I don't know if you have information that something's changed there, or if those folks are still, essentially putting pressure on Lane County when folks are having to drive a much further distance.
Yeah, so that's a great point. So we did close our Roseburg office last December. Prior to open enrollment for PEBB, all of that notification went out. We had provider challenges also in Roseburg. We could not recruit a provider that would want to work in Roseburg, which put a lot of strain on the one provider that was working in that office, and there was no appointment availability. So Willamette Dental leadership kind of took that decision last year. And I think we might have presented that back in October, that we were closing that Roseburg office. So the noise that we are still hearing could possibly be those members that still wanted to utilize Willamette Dental and were willing to travel that additional distance to either up north to Eugene or Springfield, or down south to Medford and Grants Pass offices. But we don't have a location in Roseburg. So Douglas, Coos, and Curry County, Willamette Dental does not have an office, and there's not any plans in the near future of opening any more offices in those areas, just due to the staffing challenges that we're faced with and recruiting challenges in those areas.
Thanks.
Absolutely. And so kind of some staffing solutions for Lane County that we have implemented over the last couple of months to get access back up to speed and to get back to goal, and to ensure that our members do have access to care. These are a few things that we have, Willamette Dental has done so far to date. So for Eugene and Springfield, we've added temporary coverage. So many of our dentists work 4 10-hour shifts. So we have been asking for volunteer dentists to provide coverage at our Eugene office on one of their scheduled days off, which has helped reduce that callback list. So to date, we've had 17 additional days that have been added, and we are continuing to add those days as doctors offer their availability. So our office staff work diligently each and every day to help get patients in as soon as possible. If we receive late cancellations, they're also calling patients off of that list to see if anyone's available short notice to fill that clinic time as efficiently as possible. And then as soon as a provider offers a temporary coverage day, again, that time is added and patients are called in the order of wait. We, for our Eugene office specifically, we do have a new provider, Dr. Rappel, that just started in early August. So that gives us 2 providers at our Eugene office, and to ensure that Dr. Wynn, our current Eugene provider, would continue to have a full day seeing patients and to not affect access even more, we had one of our Beaverton providers come down to do that onboarding. With that, there was kind of like a half day of onboarding and a half day of provider availability, in which they opened up that Beaverton provider schedule to see patients in Eugene, to also help get some additional patients to be seen during his time in Eugene. So with additional days that have added, and then those that we are continuing to add, as well as that new provider, we have cut down that wait list of patients by more than 50% just in the last 8 weeks. So it is getting better. We are working very hard at improving that. And so we are proud to say that it's getting better, although it's not perfect. We are on the right trajectory for that. We also did have a traveling dentist. One of our Washington traveling dentists did agree to cover some time in Eugene. We submitted that application to the Oregon Board of Dentistry in May for that reciprocal licensing and approval of all that documentation. And we haven't received any additional updates on the status of that. So unfortunately, we are still waiting on that approval. Once we have that approval, that would provide one additional provider in that office until we can get some full-time staffing, and Ryan's going to talk about that next. Just before I pass it over to Ryan, I did want to update on Albany. I didn't put it on the slide, but some staffing solutions that I wanted to provide and address. So since Albany, we do have our Corvallis office, which is a pretty close neighboring clinic. So 2 of our providers from our Corvallis office are providing coverage weekly in our Albany office to help continue seeing patients, as well as we have a Salem provider providing some days as well as a temporary solution. And then I'm going to pass it over to Ryan to kind of discuss some recruitment efforts and then our DEI information.
Yeah, thank you, Tiffany. My name is Ryan Camisato. I am a talent acquisition manager at Lima Dental. So recruiting efforts is in my lane of things I cover. We talked a little bit around the nationwide clinician shortage earlier in this meeting. To help with our access, there's a few efforts that we're focusing on. The things I wanted to highlight for Eugene and Albany and Springfield are increased clinical pay, so additional sign-on incentives for those locations, a new internal and external referral program with an increased focus on dollars for locations that we deem urgent. So that would include all those 3 locations that we just mentioned. And that would be an increased amount internally for someone that refers a dentist or a provider. And also externally, we're offering a referral bonus for anyone that doesn't even work for us can refer a dentist, hygienist. If they get hired, there's a referral bonus we pay out as well. So really opening those doors to try to attract additional candidates is what we're focusing on. We've also offered some flexibility in scheduling. So typically we've operated 410s. With the way that the labor market is right now and difficulty recruiting. We've actually offered 4/8s for our most recent hire, Dr. Rappel, to fit her schedule and make it more of an attractive opportunity for her to join. As Tiffany mentioned, we've increased recruitment for traveling doctors as well. So that's something that historically has been a bit of a challenge to recruit for, but we've increased compensation there and more of a focus on attracting some of those traveling dentists as well. As far as our assistants and our hygienist, similar to Kaiser, we have a pretty close partnership with PCC, Portland Community College. We actually held our first annual hygiene development day for them. We do a yearly DA development day, and what that is we actually invite the students to our admin facility in Hillsborough, and we provide mock interviews, resume reviews, and also they get to hear from a live panel of either dental assistants or hygienists, and just a chance for them to get some experience before they leave school with what to expect as far as joining the workforce. So that's been a pretty positive program for us, just to get some engagement with students and really allow us to interact with students in an environment where we're not doing a hiring event or anything of that nature. The last thing I wanted to highlight is we talked a little bit earlier in the call around dental therapist, and that was highlighted. We actually have 3 licensed dental therapists to expand our care as well and access. It's a new position that we've had over the last year or 2, but they do many of the basic duties of cleaning patients' teeth, but they also share some of those tasks that were once exclusive to dentists. So if you can transition to the next slide, I'm going to talk a little bit around our DE&I strategy. DE&I is something that it's essential for our bridge to our vision for being the provider and employer of choice. That's really been a focus of ours, is to be that employer of choice and also the provider where people seek us out as somewhere they want to get their teeth worked on at. One of the primary goals from a clinical perspective that we have is to reflect the communities which we serve. I always talk about the funnel, recruitment funnel. So, we're not going to necessarily go and hire a diverse candidate. That's not what our goal is, but our goal is to have the top of funnel having as many candidates from different backgrounds and different cultures as we can, and we hire the best candidate out of that pool of candidates. Some people say we want to hire a diverse candidate. My caveat to that is you have to define diversity based on what the current representation looks like. So our goal is just to focus on having a wide top of funnel, and as we narrow that down, that would increase our representation across those different groups. But we are committed to building strategies to create a fair, equitable, and inclusive environment. Understanding and learning and really improving the employee culture and experience is crucial to our vision and mission and also our core values. Our learning and development team and our department is led by a dentist actually, and supported by other clinicians. This department offers a very wide variety of trainings for us. So each year we do a cultural sensitivity training, and some of the topics that we cover It would include individual implicit bias, strategies for combating racism, microaggressions or bullying, and then also the cultural competency and empathy piece as well. If you can transition to the next slide, we'll talk a little bit around our representation of our current clinicians. So this is what our diversity makeup looks like for our dentists and our clinicians. Ethnicity is self-reported. So there are a percentage of clinicians who actually have no specified race or ethnicity, and those will be labeled as not specified. But it does match pretty well with what we saw was presented earlier as far as the numbers go. We're actually pretty close to what the annual or the national averages are. Gender of dentist is 58% male for us and 41% female, and 1% declined to answer that. And as we transition to the next slide, we'll highlight some of the recognition and efforts that are being made to continue progressing our DE&I forward. Well, it's not a new topic for us. It's definitely more important than ever before. Continuing to expand our DE&I efforts at Willamette Dental Group, and some of the things we've done there, or we've recently added a DE&I specific landing page to our website, and we're trying to funnel candidates to that page. We actually were recently recognized for a 2023 Employee Voice Award, and it's specific this year to DE&I Champion. This is our 5th time winning the award, but the first time acknowledged specifically for our DE&I efforts. We also have invested pretty heavily in our affinity groups. So we actually have 9 affinity groups, including Veterans, Pride, and African American Collaboration Networks, among others. And that's really been a big focus piece for us. It helps us, basically get a more ground level feel of what's happening in the communities that we serve, and having that representation from executives and also from our clinicians has been really key to driving those committees forward. Our focus for recruitment efforts is to increase diversity. So the things that we're doing from that lens, from a dentist standpoint, would be partnering very closely with OHSU, with Howard University. It's one of 2 historically Black dental schools in the nation, and we actually have 2 of our doctors receive their Doctor of Dental Surgery degrees from Howard. So that has been a focus, although it's all the way across the country. It's somewhere that we think would be good ROI for us, and a place that, since we have representation from there already, it's good for us to increase our recruitment efforts there. For our patients, we purposely built a web presence that allows us to see a picture of the provider they're going to meet with, the languages spoken by that provider, and also comments from other patients about their experiences, just so they have a chance to check that out ahead of time and make sure it's the right fit and feel comfortable kind of going in to who they're meeting with. But that's kind of some of the highlights that we were doing from a recruitment and DE&I perspective. I'll pass it back to Tiffany for her to cover some information just around interpreters for us.
Thanks, Ryan. So just on the next slide, Rose, just wanted to call out briefly that we do provide interpreter services. They're always available for every member interaction. So our in-person visits, or we're on the phone with our appointment center, our member services, things like that. So we do have member interaction via telephonic interpreters on site. We have bilingual staff. So I think we amongst the providers at Willamette Dental, I think they speak 28 different languages. So a pretty diverse staff in as far as that goes. If they are requesting that they wanted a bilingual interpreter that is their actual provider, not an additional interpreter, or friend and family as well. So if a member requests an interpreter, we will provide all information via that interpreter in any language. We also provide chairside interpreters for hearing impaired members, and when communicating via phone, we have the TTY-based telecommunications relay services as well. So kind of interpreter utilization, and with increased and ongoing state policy focus, we have experienced an increased volume of interpretation need and provision, along with improved processes kind of over the last 12 months, which is encouraging to see. And that wraps up our formal presentation. So if there's any questions, we're happy to answer them.
All right, I'm not seeing any questions. Appreciate the information, and also appreciate you highlighting where we do have provider access issues, and that is something that we'll probably want to hear back from you in around 6 months or so to see how that's progressing and seeing if some of those areas folks are getting into their provider. I did see that Emery has his hand up, so go ahead, Emery.
Thanks. Sorry, I had to get off my mute. I guess, in terms, as the chair mentioned, provider access, and you talked about like some members having to drive over 60 miles or travel over 60 miles to see a dentist. I was just taking a look at some ride shares. It costs like about $125 each way to go from Roseburg to Grants Pass, for example. I guess, what would you say or can do for members who need to spend that much money and time in order to actually see a dentist? I mean, what would your recommendation be to those members?
Tiffany, would you like to take that, or do you want me to take it?
Yeah, sure, I can start. And I think part of it too, as we go into open enrollment and members having the choice to utilize maybe a different dental option, maybe a plan through Delta that would have maybe a bigger provider network within those counties of areas that we don't have a Willamette dental office. I think that might be my best recommendation. Dr. Chambers, would you have anything else as far as?
Yeah, that would be my recommendation. I think when we look at the Roseburg office, and it was part of the reason the outreach was made to those patients, to make sure that they knew that that office would be closed, and to try to, obviously we'd love to keep seeing them if they would like to make the drive, but it is a long drive, and that's not going to be for everyone. It's not real convenient. And so Delta would be a good option for those patients.
Yeah, because we do have situations in which, like Eugene and Springfield, if members are wanting to be seen sooner and are willing to travel to, say, Corvallis, we do have some mileage reimbursements. But in regards to those Roseburg patients, because they're electing during open enrollment, knowing that is the travel distance, it's a little bit of a different situation in that sense. But we're happy to take back some kind of some thoughts and discuss internally too, if that's a direction that the board is interested in looking.
Greg, did you also want to comment?
Well, yeah, one of the only things that we hear, of course, is that I've been doing Willamette Dental for 20 years. The reason being is because it's good, but it's also, for me as an individual, it's less expensive. If I go to Delta Dental, I'm going to pay quite a bit more. And if there's not a Delta Dental in those areas that I can see, then I'm not only going to be paying a bit more, but I'm also going to be traveling as well. So that's kind of the only thing I have to kind of throw out there is, Willamette's, I sing praises to everybody over here about Willamette because that's what I've used forever. But in those areas, that's the one thing I could say that the reason I select Willamette is because for me, the state gives me the ability to select them because it's a great insurance for a less price. Now I have a great insurance for a more price. So that's my thought.
So one of the things I did want to ask, I want to put Cindy on the spot and ask her to give us an update just around transparency for folks during open enrollment, how far they would have to travel. And I do appreciate your candidness around, people may want to make another selection if they have to drive much further to see the dentist. So Cindy, are you able just to give us an update on how we'll be communicating that to folks during open enrollment so that they can make a decision in full awareness of where the providers are?
Sure. We have, with Tiffany's help, added some language to our enrollment guide, also some information on our website. We've tried to be very clear where there isn't access, like in Roseburg, for instance. Sorry, Siobhan, I would have been more prepared. Anyway, we have put it in a lot of different places, and we're trying to be very explicit so that members know that Willamette might not be the best option for them if they're in certain areas and where there's less access. I can provide some examples to the board if you'd like me to do that, but I don't have them right off the top of my head.
I definitely put you on the spot. And I know it's something you all been working on.
Yeah, I can share too. We provided some information and some of that stuff we responded back with. And one of it is not just our member services, but they'll have information if members are calling in to get access information, or not just if we have an office in that area, but what appointment availability is actually like. So we've geared up with some open enrollment assistance as far as, so members will have that ability to kind of connect with us to get information. Hey, I live in Roseburg. And we're going to kind of help one-on-one answer those direct questions that we receive both via phone, and then we also have like an email quick form option if it's maybe after hours and they don't have time during the workday to call in. So we are gearing up to try to be as transparent as possible throughout this open enrollment and help educate members on who Willamette Dental is, where our offices are, and that appointment availability to help them make that best decision with open enrollment.
Yeah, and in addition to that, we're recommending, well, first of all, we're trying to be very explicit that Willamette is a closed network, as is Kaiser, and that it's important, no matter what provider or what carrier that members are interested in enrolling in, that they really go out and look at provider access, whether it's Willamette, Delta Dental, or Kaiser. Because in different areas, as Tiffany said, there are more or less access, and that's as a result of the Lane County and that area. So I just want, we really are trying to not just focus on Willamette Dental, but on just make sure you go out and check your providers before you actually enroll in a plan, no matter what plan you plan to enroll in or are interested in enrolling in, so that you're not stuck later and unable to change. So
thank you, Cindy. And thank you again, Tiffany, Mark, and Ryan. We're going to move on to our next update. It is the CIAO summer update. And I believe my counterpart for the OEB board is here, Tom Siltabo, and as well as Kirsten Stavlin and Ian Chuang to present to us. And Tom, if you could define the acronym CIAO for us, I would certainly appreciate it. Thanks.
Yeah. Strategies on Evidence and Outcomes Work Group. The idea with CIAO, and it's been part of it from almost its inception, was to have a subgroup of the board that would meet with carriers and have a dedicated time where we can look at recommendation, innovation that the plans are submitting, and also use the talents of our consultants who are scanning the environment and saying, boy, you should probably be thinking about this. So it's been focused on benefits. It is a group that gives recommendations to the board, does not make decisions. It gives recommendations to the board. And in particular, as we've, as OEB and PEBB have consolidated their into one advisor consultant group, we have, and I forget the number of the bill that required OEB and PEBB to become much more unified in its various approaches. We have been actually including PEBB board members in our discussions. In fact, on the screen, I see Greg's face and his two thumbs. So Greg's been a great addition to our group, and there has been another also member who's participated. But so what we do is we have the time to be able to actually go through utilization, again, recommendations coming both from our plans and from our consultants. And what you have is this effort at looking at doula coverage and changes in weight loss drug coverage. And again, the recommendations will be there's been a research group that's looked at it over the summer. CIAL will discuss it again in when all the results are in December, and then it'll go to both boards again with a recommendation from CIAL, but each PEB and OEB will then decide whether or not to move forward on this. So that's the introduction to what CIAL is.
Appreciate that. Thank you, Tom.
Okay. Well, so I have the lightweight job of essentially introducing what we've been doing, and then our Mercer consultants, particularly Dr. Ian Chuang, is going to get into the details of what was worked on this summer. So what we're going to do is talk about the initial findings and observations for both doula coverage and weight loss coverage. And then we'll talk next steps. Next slide. So again, they were CIAL. We talked about both of these a little bit last late winter, early spring, and realized there was just no way we could get into the details of whether or not to go with this for our current plan year versus being thoughtful and pushing it back a year, but being able hopefully to make a thoughtful decision. So we developed two research groups involving, again, consultants, OHA staff, and the health plans, and we included Providence in the conversation because we were trying to come up with a recommendation that would be helpful for both OEB and PEB. And we looked at doula coverage, which we'll talk about in a minute, and a change in our exclusion to weight loss drug coverage. There was a leadership group that met to keep the group going, and then again twice monthly meetings that started in June, and those have, I believe, wrapped up now. And so we've had the recommendation, as you see in the last bullet, that the participation has been with OEB and PEB staff, OEB board presence, and then Kaiser Permanente, MODA, and Providence. Next slide. And here are what the charges of each of the groups are. Doulas, for those of you who don't know what a doula is, it is a not medically certified, but a trained person who is there to assist the birthing parent and family with pregnancy, with delivery, and then the time after. So there's both a prenatal component, there's the birthing process, and then there's the postpartum period. And the goal of the research group was to understand what the challenges were, including licensing and reimbursement, and then to study, develop a long method to really study effectiveness over time. The interesting thing about doula coverage is that we have OHA through the CCOs have already started the process for CCOs. So we could jump on that train and get some of the early findings as CCOs have tried to bring doula coverage forward. The next one is a pretty technical bit of medical progression, and it is the understanding that GLP stands for glucagon-like peptide. I don't expect any of you to remember that, but is a hormone or drugs that mimic hormones that have to do with how the brain interprets hunger and process, and there's this interaction with the body's use of insulin. So it's definitely involved in metabolism. These are drugs that are used for type 2 diabetes. And what people were very surprised was, as people were using this, a significant group of diabetics were losing weight where they hadn't lost weight before. So what has been understood now is that these drugs definitely affect how the brain interprets being full, and as compared to litany of problems associated with drugs that were used for weight loss in the past. And you can go back to the 1950s when the drug of choice was amphetamines. Well, yeah, you lose weight with amphetamines, but you also have develop other problems. And there's been, again, over the years, various drugs that have come forward. If you remember fen-phen, where significant number of people developed heart valve problems associated with it. So with that, both OEB and PEBB have exclusions for drug treatment for treatment of obesity. So what's happened is this diabetes drug is now being looked at from a standpoint of impacting, being used for obesity. Okay, next slide. So we're going to get into now for doula. Again, this describes more about what doulas are. What's interesting about doula coverage is that it looks like studies have shown that the presence of doulas, things like cesarean sections, are significantly decreased. Complications are decreased. And what's the importance of it? Well, just the importance of it is for all populations. That's a good thing to reduce maternal injury and death. However, we know that populations in Oregon that are historically marginalized are impacted to a much greater degree in regards to maternal bad outcomes. So the moving towards doula coverage may also be something that starts addressing some of the inherent racism that has permeated the delivery of care throughout the United States and specifically in Oregon. So this slide starts talking about some of those issues. Next slide. And this was a recommendation from a Oregon committee that looked at maternal injury and deaths. And they talk about the recommendations included that healthcare systems employ doulas that provide cultural and language specific support for our birthing parents. Integrate into the care for potentially up to 1 year after pregnancy, and to find incentives to be able for facilities to hire doulas to incorporate them into the care process, and then to maintain a directory for knowing who's out there, and again who are culturally specific for populations that actually maybe benefit more than just everyone else. So that was the result of this committee. And obviously we are on kind of the leading edge, and Dr. Chuang will talk some about that. So next slide, and I think Ian is next up. Ian is going to take us through the research group observations.
Thank you, Tom. And I want to thank the PEBB board and all those in attendees for the privilege of your time. So I'm going to kind of summarize some of the outcomes of the research group. With regards to the doula, this is what that research group kind of observed and the things that they focused on that was aligned with the biennial recommendation. One of it is obviously on the clinical impact. There are known positive impacts for those at-risk pregnancies due to social, economic, and social demographic factors. And it is about ensuring appropriate access to care, providing cultural sensitive support and care guidance that leads to the positive impacts and the outcomes that are commensurate to that. which is around C-section rates, pregnancy complications, and things like that. So it's really about getting to health equity around maternity care. And part of the process of doing that is the realization that it is because of the cultural sensitivity of that support, it aligns with a better positive experience for those that are of different backgrounds and different ethnic needs. Now, when it comes to network adequacy, one of the things that became apparent in our discussion and observation is there are no limitations for the doula network. And concepts like virtual doula visits may offer that additional option, especially in rural areas, kind of similar to other discussions earlier in this agenda today, that there is some disparity in terms of access and availability. So how do we provide doula where it can meet the member and deliver the best value and outcome? Other things to start to consider, again, these are not medical bodies, but these are trained individuals, but then looking to community-based organizations that are really trying to focus on and trying to build these networks of doulas with a diverse set of backgrounds to serve the diverse community needs is something also to think about and to leverage. From a benefit design, you know, the conclusion and what we're focusing on is kind of making sure that that we integrate and make sure that the doula services start to be part of the maternity care as soon as possible, from the time that potentially a mother is thinking of becoming pregnant and knowing that these services are available. And similarly, making sure that these services are not just pre-delivery, during the delivery, but also post-delivery. There's a lot of sort of outcomes, both for the mother and the newborn, that can be impacted by somebody who is culturally sensitive, aligned with that person, and helping that individual advocate and seek the care that they need for themselves. Potential challenges in delivering and offering doula services. Obviously, it's the importance of the integration and the acceptance across the care continuum, including the integration with the medical providers that like OBGYNs and other potential specialists that will be responsible for the actual care. Now, when it comes to the doula coverage, external factors to consider obviously include the PEBB consideration for that, as well as the current coverage for the OHP plan, because we're talking about the same geographical coverage where there's a limit or a constraint with potentially with the number of available doulas serving a growing population of potential needs. So those are all the factors that have to be weighed in our discussion and consideration. Next slide. Just want to pause and sort of provide some national perspective on doula coverage. To Tom's point, it is not mainstream, although there's good research evidence showing the clinical impact and the positive benefit on the member experience. There's only 23% of employers with 500 or more employees that currently cover doula based on our survey. I wanted to pull two examples, one at a state level. Rhode Island is requiring doula coverage as part of their fully insured private insurance and Medicaid population. And they're structured in terms of covering up to 1,500 for doula services. But it's based on sort of a reimbursement by following the submission of the claim as a process. The other one to just highlight is not so much, is more local and regional, is around the Providence Swedish model in Seattle, where the doula program offered to patients range based on the level of skills, experience, qualification. That's one way to sort of tier it. But they're also definitely also broadening the service to a number of other impactful areas of service, such as postpartum, bereavement doulas, with a focus on the Black African American population. So those are two reference examples. And of course, there's the OHP, where we want to learn and gain insights in terms of that experience. Next slide. And speaking specifically to the Oregon Health Plan, you know, there's plenty to learn from that. Currently, the coverage is as defined here. It's services up to 1,500 per pregnancy, defined based on 2 prenatal visits, 2 postpartum home visits, plus the delivery itself. And doulas providing the service do have to sort of meet a level of qualification and proof of training and education. And the concern and potential risk is obviously there's an onus on those individuals for the cost that is incurred, the investment of time to get qualified, in addition to getting an MPI, a provider ID that allows them to basically start to be reimbursed for their services. So these are practical considerations as we think about how do we grow out the doula networks to serve multiple population potentially. Currently, there's probably about 230 plus or minus OHP registered doulas as of a few months ago. So that's the constraint that we have in place. Next slide. So where the research group is currently is as follows. We're asking the carriers to sort of price the potential benefit option based on a various configuration of offered services, spanning pre-delivery, the delivery, as well as post-delivery phase, and to assume sort of a reimbursement set at the OHP levels to ensure sort of a level playing field as a starting point to see what that would look like in terms of the impact and potential benefit to the members. The timeline is, I believe, December for recommendation to the board by CL, followed by a January discussion by the board and a decision or recommendation. So let me pause there before we move to the next section. Okay. Let's proceed to the GLP medication. Who knew, thanks to social media and direct-to-consumer advertising, everybody knows about GLP. However, what we did was frame the coverage conversation around GLP coverage to make sure we had clarity and visibility to the broader context, the clinical context. As important, so the question is that we're trying to decide is a coverage decision. But it's important to understand sort of obesity and its role, and it's really the role and the potential impact of GLP, not just on obesity, but also the key driver that leads to obesity, which is the cardiometabolic dysregulation underneath, right? The physiological dysregulation that leads to obesity, but also the impact of obesity on a whole lot of other conditions that we know, looking at our population and claims experience, is impacted from obesity. There's this cluster of what we call syndrome, called cardiometabolic syndrome, because the underlying physiology is all integrated, and often obesity is in existence in conjunction with these other conditions like diabetes, specifically type 2 diabetes, heart disease, high blood pressure, high cholesterol. So they tend to cluster together with a very common underlying physiology that's driving that. But we also know that the presence of any of these conditions have a high correlation to other conditions that are very impactful at the member level, but also costly. That includes cancer, chronic back pain, and also osteoarthritis. So while we're talking about coverage, specifically around the risk around obesity, it is in context of these other conditions that is the downstream potential impact that we have to consider and account for. Next slide. So this research group had a few key driving areas of focus and observation. One is recognition that the chronic condition or the chronic disease nature of obesity, right? It's not just the poor lifestyle or a poor food choice or lack of physical activity. Those have impact, but obesity is a chronic disease. And I frame it as, we think about the chronic diseases like diabetes. Those are not the onset of disease, but rather the end result of an ongoing disease process, of which obesity is one of those. So it's thinking about it in those terms puts this in the proper light for discussion. The other thing to consider is around the approach to benefit coverage. So the second box here is really trying to have the conversation around, do we want to define the coverage and who can be eligible GLP, which in the sort of health plan benefit terms is a benefit design. There are the latest treatment guidelines for who can benefit from GLP, and they're based on a combination of diagnosis, severity of obesity, plus or minus the presence of other risk factors or conditions. So we can define a benefit based on any of those tiers, or we can define it based on broadly what's called clinical criteria, and it's through pre-authorization, where we're looking at the individual and using some parameters and say, if this person meets these criteria, it can be reviewed. The factors to come into play is when it's a benefit design, they're sort of hard rails in the sense that OAB decided or concluded not to recommend something, and that's just the way it is for various reasons and priorities. The other one becomes a little bit loose in the sense that it can be challenged. You can go through appeals. So the ultimate clinical and financial impact may be less predictable. So those are our practical plan design structure considerations as we go forward. The other factor to consider is, even though we're talking about GLP-1s for the treatment of obesity, because of that spectrum of cardiometabolic syndrome, GLP medications started as an indication for treatment of type 2 diabetes. So knowing that half of those with type 2 diabetes are type 2 diabetes because of coexisting obesity, many of those individuals end up being on GLP-1 medications, which is based on treatment guidelines for type 2 diabetes. So again, if it's just about restricting GLP-1 medications, we may be squeezing the balloon in the middle, but having that balloon sort of swell up when individuals progress to type 2 diabetes in as soon as 5 years. The other factor to consider is to maximize the impact, the clinical outcomes, as well as the potential value of meaningful and sustained improvement in weight and cardiometabolic metabolism. The GLP medications are recommended to be prescribed in conjunction with what we call intensive lifestyle intervention. If ultimately it's about sustaining the improvements over time, it is the combination of GLP-1 medications plus intensive lifestyle intervention, with the possibility of reducing the medication or switching to a lower cost medication or possibly coming off the medication. Because if the GLP medications is the only intervention, nothing else changes, then there's a risk of ongoing perpetual need of that medication. So something to consider over the bigger landscape of health benefit coverage. When it comes to step therapy, the considerations are whether that's mandatory, meaning you have to go through steps before we consider GLP-1 medications. Some people describe that as having to fail other options before you get the most aggressive treatment options. Step therapy can be appropriate for some of the lower severity individuals. Basically, some may respond and are appropriate to be treated with less aggressive treatment options. That versus what we call a risk-based therapy, which is looking at certain populations that are high risk and that because the disease progresses relatively quick from obesity to the other comorbidities, that we use that risk-based approach to say, hey, for these folks, in conjunction with clinical decision-making, right? So all of this is based on a recommendation from the prescribing physician that these individuals need to go on these medications sooner rather than later to get the maximum benefit and impact. And the last thing to consider is, for OAB that currently covers bariatric surgery, for those that are at the highest risk, the GLP-1 medications become an alternative option to have to discuss with their prescriber or their physician in terms of how to approach and get the most benefit from the treatment that aligns with their preference. So a lot of moving parts to consider, and that's why the research group is sort of came together to really create some criteria for decision and recommendation. Next slide. So where will we land is kind of in this continuum, right? So we are currently in a non-covered benefit state on the far right. The other option, and some employers have done this, some have done it and quickly turn it off, because when you just have open coverage of GLP-1 medications, when the prevalence of this condition is so high, without structure, without guardrails for how it gets prescribed, and there's the potential for inappropriate prescribing and use. There's a huge cost exposure with potentially inadvertent utilization and questionable clinical benefit. So the right answer for OAB will be somewhere in between through thoughtful discussion and looking at both the clinical cost, pros and cons, as well as the potential financial constraints and consideration. So we want to consider what's the scope of impact, the population that would benefit the most, and how do we address the potential cost factor, and how do we design a plan to structure that optimizes and is driving towards outcomes. Next slide. So the importance of addressing obesity, next slide, factoring time, right? So I said there's a high correlation, sorry, the previous slide. There's a high correlation between obesity and a number of comorbidities. The one that sticks out the most, if you look at this left chart here, type 2 diabetes, as soon as 5 years, there's a 4.2 times increase chance of getting type 2 diabetes in the presence of obesity, right? So 5 years is not a long timeline. And that's how quickly some of these complications develop. So that's why for some folks with very high risk, speed to optimization is key, because this disease progression is happening quickly underneath the surface. Obviously, there's some reference data in terms of the long-term cost impact over time based on different levels of obesity. Next slide. So on the OAB side, we've been talking about this approach of shifting to the left as we're looking at health plan design and interventions and point solutions to optimize health and well-being. It is all about driving or shifting to the left, right? And keeping from disease progression that is to the right. The focus around diabetes, there's a lot that's in flight currently. We have different nutrition and lifestyle programs available. And the goal is all about, for those in any of these diabetic boxes, there's the opportunity to move them and shift them to the left to a better health state. And in some cases, when they're in the pre-diabetes or cardiometabolic syndrome state, to actually reverse the disease progress and slow them down. So that's the approach for diabetes. In a similar way, we have that opportunity with obesity. Again, you don't get to obese and severe obesity without having first been in overweight stage and things like that. So regardless of where we are, obesity is a reflection of some metabolic dysregulation underneath, and the GLP-1 medications, especially for those that are on the extreme right end or those with severe obesity and comorbidity, which are the highest risk factors, the opportunity is to shift left and reduce some of that disease burden and start to alter the physiology that starts to improve some of the long-term clinical benefit and impact. So that's the concept that we're speaking about. So again, it's about GLP-1 coverage as a decision, but it's in context of trying to shift everything to the left. Next slide. With regards to the coverage for bariatric surgery, this is an illustration of some of the overlap. So these are based on American Society of Metabolic and Bariatric Surgery guidelines. The coverage guidance for surgery is basically any of these two categories of obesity, plus or minus one weight-related comorbidity, is valid for a physician to discuss with that patient whether bariatric surgery could be the right choice or option for that individual. There's an overlap with the GLP-1s. In addition, that GLP-1s includes those that are overweight with one weight-related comorbidity. So this group is potentially a little larger than the group that would be considered for surgery. So that's something to consider. The current estimates, so these are moving targets because the prescribing rates are increasing. Bariatric surgery is about less than 1% of your total population end up undergoing bariatric surgery. For the GLP-1 medications, it was kind of about 3%, but there are some groups that are saying it's as high as 8%. So the prescribing rate is continuously going up, but this is kind of the ballpark of what to think about in terms of the potential number of individuals within a group that may end up being prescribed GLP-1 medications. Next slide. And the last point to reinforce again is, although we're talking about GLP-1 medications, it doesn't negate, and this is based on recommended treatment guidelines, it doesn't negate the need and the importance of diet, physical activity, and behavioral therapy, because fundamentally it's about changing some of the choices we make that led to the initial cardiometabolic dysregulation. So regardless of where you are in this continuum, even if you're normal weight, we can all optimize our nutrition choices, be a little bit more active, especially if you're in a sedentary role, and think about how we choose to make some sort of choices that we know impact obesity, and especially the long-term impact of obesity, such as sleep, resilience, and things like that. So all of these matter, but definitely pharmacotherapy, or basically treatment with medication, starts to become relevant as the BMI increases, especially in the obese categories. And then with obviously the surgery, bariatric surgery, also being most relevant in the highest risk group. So we've got many efforts to shift left, addressing diet, physical activity, and behavioral therapy. The consideration is, do we assist that shift to the left with GLP-1s in addition to bariatric surgery? Next slide. So where we are in the process is kind of similar to the doulas, where we've asked the carriers to consider and start to do their modeling and estimation of cost of GLP-1 coverage, assuming a low-high utilization corridor, and start to inform us in terms of the potential cost ramifications around that. Next slide. And I believe the timeline for this next one is similarly December for CL to present recommendations on both doula and GLP-1 coverage options, and in January for the OAB board to comment and make a recommendation or vote on those recommendations. So let me pause there. I think there's also references in the appendix. So obviously a lot of material to cover quickly, and
yeah,
open to questions.
I have just one additional comment to wrap it up. If the GLP-1 drugs cost $150 a year, we wouldn't be having much of a conversation around this. The problem is that they're around $15,000 a year per person. Between OAB and PEBB, we have, rough numbers, 200,000 adults. The obesity rate, at least using BMI 30 and higher, it's about 40%. That's 80,000 people. If 100% of the 80,000 people said, hey, I think it's a great idea to take a GLP-1, that would be an additional $1.2 billion per year for the combined OAB and PEBB. Needless to say, that is a little higher than the 3.4%. So the complexity of this in terms of doing the right thing, there's going to be work to be able to move forward in this. The best thing would be if the drug price went down to $150 a year, but I don't think that's going to happen soon.
Really appreciate you providing that perspective, Tom. And for us, we did set aside some funds so that we could think about having a midterm open enrollment. So that's a reminder to you all. And again, as you're saying, Tom, we would not be moving the graphic you showed that just opens things wide up with no guardrails is not a route that we would be able to go.
It can't be. Yeah,
that's right. So
I just wanted to show, to talk about how bad it could be.
Sure. Yeah, for sure. And appreciate all of this information, and appreciate PEBB board members, Andy and Greg, who've been getting into the weeds on the doula coverage and GLP-1 drugs. So thank you for that. And I know we'll be hearing more. So I think we're going to move on to the joint Health Equity Work Group update. And again, thank both
Yeah,
of
goodbye.
you. I want to thank both of you for coming and speaking with us.
Bye-bye.
And I believe Christy Ewing, you're presenting for us today. And I think you are on mute, Christy. We're still not hearing you yet, and you're showing up as muted on the screen. Oh, there, it unmuted.
Oh, here, wait. I'm gonna try one.
Yeah, you sound far away. We can hear you faintly.
Okay, is that better?
Oh, yes, much better.
Oh, perfect.
Go ahead.
Thank you. Sorry, I'm still navigating being in the office today. So great. Thanks, everybody, for giving me your time to go over what our Health Equity Work Group has been up to. So if we can go to the next slide, please. So today I'm just going to share with you just some updates of what our Health Equity Work Group has been doing over the past couple months. And those pieces are really in some benefit coverage considerations, also following up with our carriers and vendors on their DEI benefit assessments. We did a refresh with the health equity screening tool, and then also I'll just close up with some future directions of our group and what we're focusing on. Next slide. Great. So this is just to show you that we have a lot on our plate. We've completed quite a few things over the past couple months. We refreshed our charter for our Health Equity Work Group. Again, we continue with these DEI benefit vendor assessments, which I'll give a little bit of an overview in a later slide. And then we've been doing some work with CEOW Group as well, providing some input from a health equity perspective to the two work groups that Tom and Ian just shared. As I said, again, the health equity screening tool, we also did an update to a legislative bill screening tool that was created for staff to look at different legislative bills. And then we also took a deeper dive into our health risk assessment, which is currently offered by the 3 carriers to make also some recommendations there. On the right side is just some things that we currently have in progress. You know, some things coming our way is that within the wellness framework that's being worked on, we will be also looking at that with health equity, looking at the strategies and tactics that that group is going to be proposing. We always take our member feedback and some benefit considerations, and they always move to the top of our priority list in addressing those when they come our way. And then we're also looking at some fertility services and benefits. And then PEBB we are undergoing right now at the Transgender and Gender Diverse Review, which is looking at the WPATH 8, which is the really the best practice for gender affirming care. And so that right now is going on. And that is also going to be supporting HB 2002 and kind of bringing to light some of those pieces that are opportunities to make sure that HB 2002 recommendations and guidelines that are needed for gender affirming care treatment are being met. Moving on to the next slide, please. So first what I'm going to talk about is just 2 specific issues that came to the Health Equity Work Group directly from member feedback. And so the first one was regarding breast augmentation. One of the ERGs brought up some concerns around benefit coverage for breast augmentation and replacement. And so the process that our Health Equity Work Group does is we reach out to the carriers. We do a deeper dive to find out exactly what is covered. We consult with our clinical team, with Dr. Twang, and really get a good understanding of what the coverage is, what is best practice. And so in this case, we follow those steps. we found out from the carriers that actually breast augmentation is covered service as part of a comprehensive gender affirming care treatment. And it just needs to be not cosmetic in nature. And then the second part of this was the replacement of a prior augmentation. And also we found out that that is covered based on medically necessary criteria, such as other medical basis for the original implant or augmentation. And so in this case, we reported back to the ERG and just wanted to make sure that member knew that, that this is covered under the plans. The second item that came to us from member feedback was regarding facial electrolysis. And so facial electrolysis currently is covered as part of gender affirming care treatment. However, in the case of this member, the member had PCOS, which is a polycystin ovarian syndrome. And oftentimes one of the symptoms of this is a hirsutism, which is male pattern hair growth. And so in this case, the member wanted to have facial electrolysis covered for treatment of this symptom. And so, again, our team does the same outreach to the carriers, again, referring, to our clinical teams as far as what is best practice and what is, what do we typically see as coverage. Through that finding, we really found that electrolysis is not necessarily typically covered. However, in this case, it does really fall under gender affirming care treatment. And so we confirmed with the carriers that in most cases they would be able to administer this benefit. And then in May, this was brought to the PEBB board, and the PEBB board voted to include coverage of facial electrolysis for members with PCOS and hirsutism. And again, we report back to the members so that they know that this decision has been made. And so just two great, I think, examples of how member feedback really comes in to what we at the Health Equity Work Group do and the process that this goes through. All right, next slide, please. And so next what I'm going to share is just with what Ian and Tom just shared as far as the two work groups that CO has. So we were, the Health Equity Work Group was very much involved in those two groups. And so first with the doula benefit work group, we did a deeper dive into the literature. We spoke with Oregon Health Plan, as far with an analyst that is currently part of that doula program. We researched what's being done across the US with different states in regards to the Medicaid population. And then as a group came up with our recommendations and considerations. And so a lot of what Tom and Ian has already shared, but really looking at the doula network, best practice would be partnering with community-based organizations, which does really support that diversity in the network to ensure that patient and provider concordance. Plan design, again, looking at as soon as pregnancy is known to have doula services begin to support the birthing person, and then extending up to 1 year post-birth. Again, a lot of times it's postpartum depression has also showed up quite often in the literature that a doula can support the birthing person getting to the resources and to the care that they need if postpartum depression is part of that birthing person's experience. Doula reimbursement, just recognizing we want to make sure that doulas are being reimbursed in an equitable fashion. What does that reimbursement method look like? And do doulas have the support in order to, submit the payments and to be able to get paid in a timely fashion? The reporting aspect is just really making sure that, that we are collecting the REAL-D, which is the race, ethnicity, language, disability reporting, so that we can monitor, if doula services are impacting diverse populations, and being used equitably. And then also wanting to have some type of standardized template for doula reporting was also an important piece that came out of the literature. And then finally, communications, just really making sure that, you know, if doula services is a benefit that's going to be covered, that the communications are accessible to all, really making sure members know right now, according to Oregon Health Plan, the doula benefit seems to be underutilized. And so really making sure that members know that a doula benefit is available. And then again, that supportive collaborative relationship between the doula and the medical care team is going to be really important for that integration and acceptance of the doula into the care team. Next slide, please. And then secondly, as part of the GLP-1 discussion for weight loss, three areas that just came out of the literature. And one thing I'll say is a lot of the literature right now is talking about, in regards to health equity, I should say, is speaking about GLP-1s in treating diabetes. There's not a whole lot of health equity research right now in regards to inequities that might exist with GLP-1 in treatment for weight loss. So we really used the diabetes research. But a couple things just to keep in mind is in a treatment perspective, there are some cost impacts, you know, for different populations. And, you know, one of the things that was interesting that came out is just there's some possible, you know, just prescriber bias. We all have biases. And so just recognizing that, you know, prescribers might also have bias. And this came out of just some research that was done by the VA, where they controlled for socioeconomic and some of those other barriers to access. And there still was disparities as far as between the prevalence of diabetes and being a good fit for medication, and then actually prescribing of the medication. The plan design, you know, just some things to keep in consideration is obviously a high deductible health plan will definitely have a disproportionate financial impact. And then what, you know, different populations having different options and just making sure that there is consideration to those, and if there needs to be any type of travel or virtual providers, things like that. And then lastly, integration of lifestyle behavior change. Social determinants of health come in a big way here as far as access to nutritious foods, you know, time to get out and exercise, being able to cook at home, and then just the impacts that stress and other, you know, other lifestyle factors and things that can have on being able to, you know, spend the time and the energy and the money in order to really practice behavior change in these areas. The other thing that's really important in this as well is that as we look at lifestyle behavior change programs is going to be focusing on you know, and making sure programs are incorporating all different types of cultural diets. There's been also a lot of research on that, and that there is a lot of efficacy around diets or eating patterns that take into consideration cultural preferences that are still very applicable and supportive of weight loss. Next slide, please. Awesome. And then this one just to show, several years ago, we did a DEI benefit vendor assessment of PEBB's carriers, long-term disability provider, and I think EAP providers as well. And so I won't read through all of this, but just letting you know that this is we continue to follow up with each of the vendors, and the areas in general are really looking at that provider diversity and demographics, looking at how, you know, the different vendors are addressing social determinants of health, you know, if they're using different platforms, what is their reporting like as far as monitoring for inequities with different programs. And you can see we kind of have these strewn out against over the year, where we have kind of a cadence that we follow up with carriers and vendors. Next slide. Awesome. And then with our health equity screening tool, and so the health equity screening tool I've presented on previously, where it is a tool that's been developed that allows us a kind of a starting point when the health equity work group looks at a program or a benefit resource to start the conversation around health equity considerations. And so the tool just is a dynamic, evolving of product that we use, and we just always want to make sure that it is up to speed and updated to be relevant to the work that's ahead of us. And so this just kind of talks about some of the updates that we did this year. So we want to always make sure that the language is updated. We did add this time around some readability guidelines. We added some NCQA health equity questions to it now that there's that NCQA health equity standardizations. We updated the list of the populations to be the most updated. And then one thing too we've changed on the tool is that in the past, it really just referred to evidence-based guidelines. And so we've broadened that language to include consensus and community-based, just recognizing that it's not always evidence-based that is the best, is not always the one and only aspect to keep in mind when we're looking at if something is a good program or resource to bring forward to the PEBB population. Additionally, we put the screening tool through an accessibility guideline group that we have at Mercer, and they also made some great recommendations as far as the grade level that the tool is now at. We've added definitions to the tool and also an introduction page so that anybody using the tool would be able to have access to it. And I think I have one more slide. Awesome. And so just wrapping up, we have a lot on our plate in the next couple months. So as I said, future directions as that our gender diverse and gender affirming care benefit review comes in, and then also weaving in that House Bill 2002. We'll be presenting those findings. As was presented today, our dental preventative care and treatment, and looking at that a little bit deeper with the health equity work group. We have our framework strategies and program review that we'll be diving into the next couple months. And as always, we have our member feedback and considerations always rises to the top of the work that we do when those come our way. We also have, I know PEBB has some listening sessions that are going on right now as well. And so that's on our future roadmap as we hear member feedback from those listening sessions, we will also take that into our group and start working on those. Yeah, just looking at as we go into our board meetings as well and the retreats, looking at our guiding principles and other documents that we have. I will pause. I know that was a lot. So any questions or comments?
Appreciate all the updates, Christy. And I'm recognizing that you graciously agreed to present today and you were prepared to present at our last meeting. So thank you for coming back and sharing with us. And I'm going to move us to our last update of the day, and that Margaret's going to share with us what the innovations work group has been up to. So go ahead, Margaret.
Yeah, hi, good afternoon. Can you hear me okay? Great. Yes. Wonderful. Okay, I have a pretty quick update today regarding the innovation work group. The work group itself took a little bit of a hiatus over the summer, so has not been meeting the past couple of months. It will reconvene later this afternoon at 1:30 today. And looking at sort of just kind of some logistics for the work group in the coming months, we are actually looking at some membership transition. There are a couple of members of the OEB board who've been very active in the work group. JJ Schofield, who has recently resigned his seat on the OEB board, and then also Jeff Brown, whose tenure on the OEB board is coming to a close. So we're looking over the next couple of months at doing some recruitment to pull in some additional board members to participate, both from the OEB board as well as from the PEBB board. Right now, Kimberly and Sean participate in the work group from the PEBB board, but I think we would love to take this as an opportunity to maybe find another PEBB board member that would also be interested in engaging. So that all said, in terms of the schedule, we're meeting this afternoon. We expect we're going to take a little pause in October to give board members, as I said, these transitions, time for board members to get on board and recruit some additional participation in the work group. And then expect the work group will pick up again later in the year and do some review of the work plan and kind of scheduling out of priority projects. But of course, the main project that has been in process for a while now is around the Centers of Excellence project. At this afternoon's meeting, the work group will review sort of an update of work to date on that project and how things are progressing, as well as a revised timeline. Recently, we did have the opportunity to meet with some members of the Oregon Association of Orthopedic Surgeons and share an overview of the Centers of Excellence project with that group, engage in some dialogue and hear some questions from them. I think generally, they had good questions, and the concept of a Centers of Excellence program seems something that they, noted was very in line with their philosophy on approach to patient management. So we absolutely agreed to stay connected with them as we move further along. Right now, we're working to get updated quality metrics pulled together and expect that analysis will likely be done probably close to the end of this calendar year in terms of when we'll have updated APAC data and run updated quality numbers, begin to look at those in more detail and sort of identify those facilities with the highest performance and lowest complication rates. We're looking at an approach that's really going to involve member education and information as an initial phase. I think the work group, of course, is still working on recommendations for the boards, but I think likely those recommendations will probably point to a phased approach where early phases really focus on sharing quality information with members to help guide decision making, with a longer term strategy that would look at potentially recommended plan design changes or other incentives or features to encourage members to go to those highest performing facilities. A couple of other topics that are on the work group's work plan for later this fall as well as into next year. One of those being review of hospital payment cap data. This is sort of part of just our sort of annual compliance review to ensure that under the hospital payment cap, payments for inpatient and outpatient services are remaining below the 200% Medicare level as required by law. We are also looking at some updated data on level of payment. So how do PEBB and OEB payments for other services beyond just hospital compare as a percentage of Medicare across other categories of services? And are there opportunities in some of those other categories of services around payment rates? And then also looking at value-based payment progress, including we anticipate having some updates and recommendations from the value-based payment compact work group later this year for the boards to potentially consider in terms of what we require in our contracting with carriers. Also, some further cost and utilization analyses in the queue for the work group. I won't get into too much detail on that, but happy to pause there and take any questions or invite Sean or Kimberly to chime in if there's anything they want to share.
All right. Well, thank you so much, Margaret.
Yeah, and thank you.
We are reaching the end of our meeting. I know that public comment was submitted from the Oregon Medical Association, which was emailed out to you.